Please help me welcome Paul Gilbert.
Well, good afternoon. Thank you so much for having me today. I'd like to share a story with you today. And the story is about a mission to enable more effective and safer mental health drugs to come to patients faster. It's a story about commitment and sacrifice, and ultimately it's a story about the extraordinary obstacles that entrepreneurs face, if not impediments, in trying to bring much needed innovation into the clinical trial space. And the reason I want to share this story with you is that I'm hoping on the other side that each of you, when you are in front of future entrepreneurs, you might find ways where you could be supportive of their efforts, because if we all wait until an innovation is proven 9 ways from Sunday, makes it very, very difficult to bring these needed innovations into our market space. So I'd like to share something private, which I oftentimes don't or rarely talk about, but I'd like to start it off this way. My father had bipolar disorder. He recently passed. My brother has suffered from severe depression, and my uncle committed suicide due to untreated depression. And 15 years ago, they all went on to have they all had extraordinarily successful professional careers and academic pedigrees, but their interior lives were injured. And 15 years ago, when my daughters were young, I was very fearful that unknowingly I perhaps could be a carrier of these genes and passed it on to either one of them. And I started to do research on what was the state of psychiatric drug treatment. God forbid either one would ever need it. And what I quickly learned was that pharma had an intractable problem, and it was the unsustainably high rate of inconclusive trials in mental health. Half the time that pharma tests drugs that they know work, like Celexa and Paxil and Wellbutrin, pharma can't show that these known effectives work any better than the placebo. And I knew that if pharma didn't fix this problem, it would only be a matter of time before pharma would give up on investing into psychiatric drug treatment, as in fact was the case. So I said, well, how can I do something about this? I can't be a scientist, I can't be a drug developer, but as a very, very concerned father, as a business person, perhaps I could bring some novel thinking to how this issue could be addressed. And that's what I committed myself to doing. So my co-founder and I started MedAvante 15 years ago. We were, even more so in hindsight, woefully unprepared, completely unsuited to the task, and yet consumingly devoted to this mission for the next 15 years of our lives. And I wanted to share with you some of the stories and struggles that we faced early on, because I think they're illustrative. So this is a picture of my daughters when we were starting out, and I'm not going to keep it up because it'll bring tears to my eyes, so I can't look at that, but I just wanted to quickly show it. And this is the problem that we were seeking to solve, that again, half the time known effectives can't show that they're better than placebo. And when we understood the nature of the problem, we saw this. The distinguishing feature of mental health clinical trials, as many of you know, is that they're subjective in nature. When you look at most of the other therapeutic areas, you see hard, easy to measure endpoints. Bone density, mortality, tumor progression. But mental health is so soft and squishy. Does Mrs. Smith meet diagnostic criteria for depression, or is she just having a situational bad week? Is Mr. Johnson improving or not over the drug treatment? And as such, because of the subjectivity, there's so much bias and variability that's compromising these studies. So when we understood the nature of the problem, the solution almost fell out. Like labs were centralized, like EKGs were centralized, why couldn't you centralize the assessment of mental health patients? So that's what we decided to do. And I'm going to briefly describe how it works. It is not an advertisement for central ratings, but I just want to be able to explain it because it allows me to illustrate the points that I'd like to make in this talk. So how does it work? Let's say Pfizer is running a clinical trial. They're looking for severely depressed patients. They go to 100 research sites. And let's say Dr. Patty is one of the PIs. Does she want to participate? Of course she does. All of the PIs, for the most part, want to participate. And she starts recruiting. I hear the advertisement. Assume I have moderate depression. I show up at her front door. Now what happens? She has a misaligned economic incentive to inflate my score. Could she tell me, Paul, you're not sufficiently depressed, you have moderate depression, you need to go home? Yes, she could. But too often, whether for conscious or unconscious reasons, there's a $15,000 or $20,000 incentive to make sure that I am severely depressed, at least at the baseline. This way I'm in a study, Pfizer's happy with the recruitment rate, and everything goes on. Except there's a problem, and the problem happens the next week. Because now I'm in the study, my baseline is measured to be severe, and that's only an artifact of this misalignment of incentive. I come back the next week, and now Dr. Patty scores me as I really am, moderately depressed. So what's the problem? The problem is it just shows that I improved from severely depressed to moderately depressed. And what happens if I'm on placebo? I show strong placebo response. And imagine that's not just happening to me on placebo, it's happening to hundreds of patients across the clinical trial footprint. Many of them are improving because of this artifact. So that's bias, and it's pernicious, and there are other forms of it. Variability is simpler to understand. Let's say there are 3 clinicians that are interviewing me. Each will elicit and score my information differently in this trial. One might score me at 20 on a Hamilton Depression Rating Scale, one might score me at 16, and one might score me at 24. So what am I? So between the bias and the variability, you have what you have, which is this disaster. There's no way pharma could continue to sustain a strong investment into a category where half the time they get the known effectives wrong. So the solution that presented itself was to centralize this assessment. We could bring objectivity where there was bias and standardization where there's variability. So how does the objectivity work? By centralizing the assessments, we put 2-way high-quality video conferencing into all of the research sites that a Pfizer would use. And the patient would show up, everything would happen at the local site as it normally would, except the assessments would be done over 2-way high-quality video conferencing, run over the internet, and we would have a centralized cohort of PhD clinical interviewers. So objectivity, we're paid to do assessments. Whether the patient gets into the study or not, we're paid the same. We're economically indifferent. The clinicians are blinded to visit sequence. They don't know this is the baseline where they have to score up. They don't know if it's a midpoint or the endpoint. All they know is that a patient showed up at a local site, is presenting on a screen, and they have to interview the patient. So that brings objectivity where there's bias, significantly depressing placebo response. The variability, that was actually easy to solve. In a clinical trial and trials, Lilly wants the raters to rate one way, Pfizer another, Glaxo and Novartis a third and a fourth way. There's so many idiosyncrasies between each of the sponsors. With MedAvante, the clinicians are trained and calibrated over and over to single standard, which is the MedAvante standard. So that solves the problem, the objectivity and standardization where there had been bias and variability. And it had face validity. We went to the head of Psychopharm at the FDA and he said, this is so elegant. I don't know why anyone didn't think of this. So we, in our naive way, thought, oh, this is going to be easy. Before I get a chill just thinking how dumb we were. I'd like to share how dumb we were, actually. So we were going weeks, months, quarters, and nothing was happening. We were getting lots and lots of meetings across pharma, lots of positive feedback. No one was biting. We met in the first 3 years 535 people, and the head of clinical operations at Pfizer at the time, Dr. Atta, said, we're going to break down your door to give you business. I didn't hear any knock from him. Other sponsors said, we're going to be an early adopter. Here's what we need you to do. Just get 3 or 4 of our competitors to prove it, and we're your early adopter. So that sounds good to us, except the others didn't want it either. So we thought, okay, here, maybe we need to look bigger. And these are the things that are going on the other side of the table when you're talking to entrepreneurs. So we got a little office space. We were going 3 years without salary, so we couldn't get a big office. We got a little office and had 2 secretarial desks. And we were working so hard trying to get this going that we would sleep under the desk. But that's a whole different story. But I have some great photos of my co-founder sleeping under the desk. So when we would schedule meetings with pharma to come meet with us, I was doing the scheduling, and I'd say, let me look at the, we had a fourth floor conference room in a nice building in the middle of Princeton. An early supporter loaned it to us. So whenever sponsors would come over, I'd say, let me look at the available conference room schedule. And I'd look at the schedule and I'd say, oh, we have a fourth floor conference room, we'll meet you there. Of course, there only was the fourth floor conference room. And unfortunately, most of them didn't figure that out. And even better yet, at the end of the conference room, there was a door. And the door opened up on a neighbor, Domain Venture Capital, which was running a bustling office. So whenever a farmer would come over, I'd go over and I'd open the door, and suddenly MedAvante was bustling with people. When Patty says I was smart, I'll take credit for that. That was my big idea. I had a lot of terrible ideas. Here comes the one that wasn't so good. Well, more time goes by. At 3 years, we're really getting desperate. We'd hired some people. We weren't making any salary. And we said, okay, the venture guys won't touch us until pharma gives us a break. Pharma's not going to give us a break until we get funding. We're caught in this terrible loop. So we needed to raise funding. Before we could raise funding, we decided, well, we're going to need to show funders some data. So we said, let's put together a pharma consortia. And we called and we called and we called and we called. And we did put together a big pharma consortia. It was Lilly, Pfizer, AstraZeneca, Bristol Myers, and Organon. And we called it a big pharma consortia, but really they only put in $10,000 or $15,000 each, probably to stop us from calling. We generated some very powerful test data. We showed that patients in mental health trials are more comfortable sharing intimate details about themselves to a remote clinician over the video conferencing than they are talking about, say, sexual side effects in front of a local doctor whom they might even know socially. And there was no loss of clinical information. So we thought, this is powerful data. Pharma will engage now. So still not. So we said, let's go get the funding. So we said, if we're going to solve pharma's problem with these failed trials, we're going to need to be a global organization. We're going to need access to unbelievable talent. Another big idea, why don't we get people who've led pharma organizations to invest in us, and we'll tell them we'll only accept their investment if they give us 2 or 3 meetings a year. So it sounded plausible at the time. Right next door to us on this fourth floor was the former vice chairman of Bristol Myers Squibb, Dr. Ken Wegg. Dr. Wegg, some of you may know, was an absolute serious no-nonsense guy. Now, I could hear through the walls that Dr. Wegg would go down the hall at 10 a.m. every morning to the men's room. So what do you do when you haven't had salary in 3 years? You're going to go to the men's room at 10 a.m. So I started developing a rapport with him. I started sharing the value proposition. I know it was a little presumptuous. Shared some of the data. At the 3-week mark, I felt I was good enough. I was going to go in for the ask. So I go in, we're talking again, and he asked me this absolutely shocking question. He says, Paul, are you following me? I was so taken aback by this horrible question, aside from the fact that it was true. The only way I could think to respond briefly momentarily was to say, Ken, this is so awkward. I was wondering the same about you. You have to think fast on your feet. He did not invest, at least not that round. He came in later. But we did raise $2 million from organizational leaders, the former CEO of Glaxo, the former president of Bristol Myers, the former CEO of Citigroup Global Consumer Banking. And we actually, I'll skip ahead, we went on to raise a total of $50 million, and 14 of it were these are business leaders. These are some of the pharma leaders. One of them is now the head of the FDA. The first one, Dr. Scott Gottlieb. For the record, he sold his investment before going to the FDA. He had been on our board for 10 years. So we raised ultimately a lot of capital, 94 strategic investors, one who's not strategic. That's my mom. You have to let in your mom. Okay. So we got the capital then. Then we said, well, now we have the capital. Will pharma engage us now? Still pharma wouldn't engage us. This is 3 years, so this is really, we're getting desperate. So then we said, well, decision makers in pharma appear to need key opinion leaders to give them permission to do new things. So let's get the key opinion leaders together. So we convened 12 of the elite key opinion leaders in CNS who all recognize the validity of this methodology. And we said, okay, let's bring in 3 or 4 heads of CNS from pharma, and each will look across the table and wonder if his or her competitor is already ahead on this, and they wouldn't want to be a laggard. And that's how we got our first study. We, I hate to say it, but tricked BMS into thinking we were already well along. Bristol Myers, Dr. Jack Webb, we love that man, gave us our first break. So, and then disaster struck, and we had 9 near-death experiences. There's so many disasters, but there is a happy ending, which I will definitely share with you. Don't let me forget the happy ending. So I shouldn't laugh, but Dr. Webb passed of cancer in the study. The study was, during the study was inherited by a junior team. They read out the results. They didn't share it with us. They sent it all the way up to the head of R&D. I think his name was Elliot Cohn, but I'm not sure. And then they brought us in, and they showed us this very crude analysis. They showed an XY scatter plot, change score for central ratings per patient and change score for site-based ratings for a patient, just an XY scatter plot. And they said, well, look, it sort of clusters along the line. What's the difference? And we were shocked. So we came back with a very senior, very widely regarded academic statistician, and between him and my co-founder, who's brilliant, they pulled more data out of this team. And then Dr. Leon, the statistician, said to Bristol Myers, he said, you don't have just a good result comparing site and central ratings in the study, you have an extraordinary result. Central raters could run the same powered study with 1/4 the number of patients. And we finally thought we were delivered. Bristol Myers would engage this. They would be sure to tell their brethren across pharma that this unsolvable problem had been solved. And my co-founder, Amy, and I could go on with our lives and leave this to the scientists. And no, that team was not going to run that back up the flagpole that they got it so wrong the first time. So what should have been a triumph turned out to be another, frankly, disaster. So we had to raise more funding. The only reason we raised $50 million is it took so much longer. We originally thought we'd need $4 or $5 million, but pharma was so slow on absorbing this that we had to raise a lot more funding than expected. So slowly the study started to come in. As we moved towards 07, 08, we started in 02. There are some lessons learned. One is FUD, fear, uncertainty, and doubt. And there's not an entrepreneur who's not familiar with it. In any ecosystem that's broken, there will be participants who profit from that brokenness and want to keep it broken. Another threat to us is that pharma would not share the outcomes. We were generating really powerful outcomes, and each sponsor would say, you can't even tell our competitors that we're working with you. You are our golden goose, we invested in you, we believed in you, and we're not here to help our competitors. So, you know, I wasn't obviously doing this for the money. I was doing this for selfish interests as a father who cared deeply about my daughter. So this was despairing news that we couldn't show the power of this methodology. So the adoption rate was much, much slower than it should have been. Another finding is that experts can be very myopic. So-called experts, they're usually self-appointed. They are very embedded in the way things are done. They like the way things are done, and to change is to threaten them. And if you doubt that, you could read Kuhn's Scientific Structure of Revolutions. It was in the 1970s. It's a brilliant book. He says you can't convince them. You just have to wait for them to die out. But we didn't have time to wait for anyone to die out. We were dying first. So, and then we discovered even when we deliver big outcomes, we couldn't participate in the share in the value that we were creating to invest into more innovation. So here's one example. This is a textbook one. Acadia has a different administration now. This was a prior one. They had a treatment that could address Parkinson's psychosis. There was a big need for this. No one had cracked the code on it. They thought they cracked the code. They ran a study with traditional local site-based raters, and they showed no signal between the the test drug and the placebo. And the market cap cratered. Wall Street punished them. They went down to $56 million market capitalization. They reran the same study with central ratings, and when the study read out to Wall Street, the result was so powerful because there was so much signal there that their market capitalization went up over $1.7 billion. We helped to contributed to making centimillionaires out of I don't know how many people there, but what did they do with this bounty? The days before they announced the results to Wall Street, they negotiated the second contract with us before we knew the outcome, and of course it was at the same price as the first one. Wow, not classy. Okay, I kept that to myself. One last year, and then I'll fast forward. 2008, we all know this was the year that the world imploded on so many of us. We were negotiating with Goldman Sachs. They invested in one opportunity in 100. This would be so validating. They took 9 months doing due diligence and making up their mind. And by the grace of God, they decided to invest 2 weeks before the crash came. So had they waited just another 2 weeks in their 9 months, we would have not had the wherewithal without that 20 million to survive the coming storm. But what we did with that funding is to invest in new innovation. What we observed, well, the innovation was we developed the world's first electronic clinical outcome assessment. And we observed our clinicians, and we took only 5% of the applicant pool, so we had great clinicians, and we saw even the best clinicians, when they're working with these big, thick, complicated mental health rating scales, we would see at times they would be inaccurate, they could be incomplete, there could be variability in their answers, then someone would transcribe it into metadata, there could be transcription errors, and then of course the monitors had to come out, and that was expensive. So we said, well, let's take a tablet. This was before the iPad came out, so we came up with a tablet form factor, and that was an early model. We embedded rich clinical guidance into it, branching logic, and electronified it all. And now as clinicians went through, they were guided to ensure that it was complete, it was accurate, it was standardized, no more transcription and no more paper, so the monitors stopped coming out every month or two. They started coming out every 7 or 8 or 9 months. So that allowed us to then globalize. Lily said, we want you to go to Russia. We surveyed the team, does anyone know anything about Russia? Some of us like borscht, and that was most of our credentials that we could come up with. For the women in the room, we brought in the country manager of Pepsi to tell us what the culture of Russia is like. And he said, well, if you laugh a lot over there, they'll think you're an idiot. So my colleagues, since I laugh a lot, helpfully said I shouldn't go. And then of more concern, he said, and you can't hire a woman as a country manager. Men will only accept taking directions from men. Now, I have 2 daughters. There's no way we're not going to hire the best person, and I would really hope it would be a woman, just to make the case. And in fact, we found an MD, PhD, MBA, brilliant woman, and it wasn't because she was a woman, it was because she was by far the best candidate, and she did a brilliant job. So much for that Pepsi country manager. A bottle of sugared water. So finally, this thing started to take off. And we finally got it going. And we went from bricks and mortar, paper and pen, and US based. It became digital, global, and virtual. And you can see we're coming up on a happy ending right now. And then pharma in 2013 said the failure rates in CNS are too high. And they did, the whole reason for my starting this was because my concern they'd pull out of psychiatry. And they did. And our sales plunged. And it was shocking to us. We lost a third of our treasured 200 colleagues because we had to do a headcount reduction. But one good thing, we built a culture based on respect. People come to MedAvante and they know they're going to be cared about, they know they're going to be respected, they know they're going to do important work, it's going to be hierarchical, there's going to be no politics, and you know what? Not one of the remaining 125, to the best of my knowledge, left for the next 5 or 6 months. We held together because of the culture, and that gave us time to reinvent ourselves. And my co-founder and I said, let's take, remember that eCOA platform that the first that Goldman funded in 2008? We said, let's take that, let's reposition it as a signal detection platform, industrialize it, and we'll give a big advantage that our central raters have, we'll give that to site-based raters through the sponsors. We'll go to Glaxo and Novartis and whoever else, and they can give it to their site-based raters. And it would really help their accuracy. Here's how Virtual helps. By building in rich clinical guidance, it took the error rate that a local rater 41% of the time would make at least one error. Virtual will reduce it to 9%, and 16% of the raters would make 2 or more errors, and we reduced that to virtually nil. And pharma loved it, and the thing just took off. And then in the first quarter, it came in at, this year, it came in at 42 or 168 million run rate. That's 16 times where we were in the trough of 2013. So, last learnings. You're oftentimes, when it comes to innovation, going to find entrants doing the innovation, not incumbents. Incumbents know how damn hard it is. They know that they're not going to get paid. They know they're going to be knocking their head for months, quarters, years against the wall. And lo and behold, that's why you have outsiders like us. We were outsiders coming in because we were so naive. We didn't know how hard it was to bring change into clinical trial ecosystems. The last one, build a better mousetrap and the world will beat a path to your door. This was a better mousetrap. We took the failure rates from 50% for known effectives down to the low teens, high single digits. It was a scientific triumph. It solved the problem that pharma needed to solve to continue in mental health and to continue to invest. And I shared with you just some of the travails that we endured to get there. But for me, the happy ending is this. Sorry. This was... This was 3 weeks ago. That's my mom. She's 79. She can do a 3-minute plank. And she brags about this to me. She should. I think that's pretty cool. That's my oldest daughter, the taller one, and my youngest daughter, Lexi. The oldest one, Kayla, 3 weeks ago just graduated from University of Pennsylvania School of Engineering, and she was their one admit into Google's elite product management training program. And the youngest one, she's just finally blossomed, and she's happy, and that means I'm happy. So thank you so much for your time today. I really appreciate it.